So we all agree that computer has invaded every part of our life. And the question is, why not in surgery? If you look at the operating theater many centuries before and the operating theater of today, virtually everything has changed except one thing, and that is the surgeon himself. So there is a lot more if we could increase the accuracy and consistency and precision of the surgeon himself. On the other hand, spine surgery has become more complex. There are more instrumentations, more patient expectations, and poor results with medico-legal issues. So we all look at surface markings for introducing our screws, but in some areas like this, where the anatomy is completely altered, either congenitally or in formation, or developmentally by trauma or some other pathologies, when the anatomy is completely altered, it will be really good for us to see beyond the surface and to see beyond the human eye. Now, all these people are really worldwide stalwarts. They are experts in the field. They are the best in the world. But even for them, we know that there are good days and bad days. And similarly, even the best of the surgeons have the bad days. Now, this is actually not from an institute where surgery is done little. It is from one of the most premier institutes, and you can see that there was multiple sacroiliac fixations done. Patient woke up with a carda equina, and a CT was done immediately, and you can see what is the reason. Virtually every screw is inside the spinal canal. And no wonder that from time to time such major disasters take place. And the question is, would the accuracy be increased by use of navigation? Now, regarding the accuracy, it has been proved well beyond doubt that navigation increases accuracy. So in this meta-analysis, you can find of the 30 studies, with conventional fluoroscopy, then you have an accuracy of only 68.1%, and this can be tremendously increased to 95.9% accuracy when you use navigation. So accuracy is no longer in doubt. But I would like to point out some of the few advantages of having a navigation as an aid for you when you are doing difficult surgeries. In fact, navigation allows you to expand the frontiers of surgery. And in many areas where you would be very worried to put in a screw and it's almost impossible, navigation allows you to have a secure fusion. Now, this is a 45-year-old male traveling on a two-wheeler, and you can see that there is a very complex Jefferson's fracture. Normally, this would require, because of the splay of the fragments, that you need to do an occipito-cervical fusion till there is a fusion. But here you can see that because there was a navigation, it is quite possible, even in this displaced position, that you could apply screws with a burr very carefully, and then you can use a monosegmental fixation so that this patient has a very good result and he has a very good function over here. So something that you could not have done without navigation, it allows you to do better when you have navigation. Similarly, you can see that this is a few months old C1, C2 subluxation, rotatory subluxation. Now, when this patient came to us, we put him on a traction, and that did not create much change, and so it required fixation. Now, in this sort of very altered anatomy, you would agree that it is very difficult to put in C1 and C2 screws very confidently. But with navigation, you can find, even in this altered position, you can get a high level of accuracy. You can put in a C1 and C2 screws, and then use this as a lever arm to get a good reduction. And you can see that the screws placed even in this altered anatomy are really good, and you are able to get back a complete. So again, a game-changing advantage for the patient because you are able to do this. Now, if you have very complex deformity and with an altered pathology, again navigation comes into full use. Now, this is a gross kyphosis, cervical kyphosis. Now, you can see this is a problem of neurofibromatosis, 161 degrees in the cervical region. And because of the gross kyphosis at the cervical region, you can find that the whole of the thoracic spine has become lordotic as a compensatory curve over here. But more importantly, you can see that the pedicles are horribly bad. They are very thin and very penciled out, and here the fixation becomes a major challenge, and navigation really helps you to secure fixation at multiple areas wherever bone is possible. Now here you can find in these areas the whole of the body is completely eaten off, but it still allows you to look at angles and trajectories where you can get reasonable amount of bone, and you can do multiple areas of fixation so that once you have done this, you can get a good correction over there. Now all this will not be possible if you are not able to have organ. Now here about a question. If you are using it for straightforward cases, then fluoroscopic or 3D CM navigation is okay. But if you are using it for severe deformities, then you will have to be careful that you use a CT navigated navigation. Because whenever you get a very gross deformity like this, there is a problem in fluoroscopic navigation. Now in thin patients and cervical spine, it is easy to use a 3D navigation, because you can see that either in the AP or the lateral view, as the CM rotates, the spine can still be in the center of rotation. But however, if the patient is very obese or if there is a severe deformity, then you will find that what is in the AP view is not caught in the arm or by the lateral view, and then you get a very bad picture over here. So that is the need that when we are doing very complex cases, an intraoperative CT acquisition is useful. So we have found a big change after we have utilized this, because in this the gantry is really wide, and then when the patient is on the table, you expose the patient, you do come to the stage where you are ready for your navigation and introduction of the screws, and then you mark the areas where you want to have the navigation, and then the patient alone, and then the CT moves in and out, and this only takes 18 seconds for the whole of the spine and for navigation, and then you are ready without any need for further registration. You can go ahead with navigation. The bore of the CT is also 20 centimeters wider than the normal CT which you have in the radiology department, and so even for this patient who has 130 kilos weight, you can see that the quality of navigation is really fantastic. Now, all the studies done so far have been evaluating the use of navigation and accuracy in normal pedicles. But we know that the pedicles can be good, bad, and ugly. For example, you have thin and thinned out pedicles, but also you have pedicles which are very thinned out and wavy, and these are all called the ugly pedicles. So no big study has been done on completely altered pedicles. And that is why we did a prospective study and then published in the European Spine Journal, where we classified the pedicles first. Grade 1 was quite normal pedicles. Grade 2 was primary surgery with in spinal deformities. Grade 3 was revision surgery and altered pedicle anatomy. Grade 4 was impossible without navigation, and grade 5 was pedicles where you should not use a pedicle screw. Now, on this ground, we actually evaluated on cases where we had a total of 488 pedicles of grade 3 and 4, which means that these were pedicles which were very challenging and would have been a great risk to put in screws. And we found even in this, there was an accuracy of 97.7% with CT time. Now, whether you will use a computer navigation versus robot, robot's usefulness is restricted to screw placement, but is not useful on a surgeon-guided flow, and therefore it is not useful in tumors. For example, if you are doing a tumor like this, normally you will have to do a good exposure, but here you can use a minimally invasive procedure. You can see that there is a tubular retractor over there, and you can go up to the depth because you can guide your drill over here. You can see that this is the vertebral artery, but as you bring in your instruments and then you cure it and then you drill, you can find that you leave a thin mass of bone over there, and here you can see that this is the pre and post-op. You can see all have been removed by a small tubular retractor. So you can see that this one is in the thoracic area, and once you fix over there, all that you need to do is to put in your tubular retractor and then use your guide. And this is you don't need to use any instrumentation because the surgical scar is only 3 centimeters and the patient can be up and about walking the same evening. Another big use of navigation when you do tumors is that intraoperatively you can assess again the adequacy of your tumor removal. This is an osteoblastoma, and this has been removed by a tubular retractor approach, minimally invasive. And you can see that after you think that you're completely removed, you just do one more rerun, and then you actually find that a little bit of tumor is left over the side, and then you can go and remove. That gives you the safety that after you have performed any of these procedures, you can do a trial run before the patient is, while he is still in anesthesia and before he is to go out, so that no need for the patient to come back. Anything that needs to be redone can be done under the same anesthesia. Now, robot is comparing again navigation versus robot. Robot is not only more expensive or the initial investment, but it is also expensive on every case you do because there is a disposable item of the arm and then that is very time consuming, whereas that is not present in your navigation. So it is not that navigation is the best. It is definitely good. We can know that is it because it also reduces your operative time. And this we really find it very useful when you do difficult cases. There is no major change in the operative time when you do normal routine cases. But when you're doing very complex cases, for example, a very complex deformity, at about 6 or 7 levels of the pedicle, if you need to have a fluoroscopic guidance, then for every level the C-arm has to come and positioning is difficult and then you verify and you are standing close to the C-arm and you have your hand inside the field. So not only the radiation is a big hazard, but also the amount of time taken for each of the screws becomes very high. And here the navigation really scores over very high. Now this is a point in fact. Now this is the amount of radiation you get according to the distance from the field. This is very high zone and we really need to have your hand inside when you do a fluoroscopic guidance in a challenging pedicle. As you come closer and closer, there is a very high radiation. But when you do a CT guided navigation, in the 20 seconds that it takes to scan, you can actually stand outside the room and then you are zero radiation, and it's a long time since I have even worn a lead apron for any of these kind. So that is why you find that actually, unlike popular belief, your radiation for the surgeon is actually much less when you use a CT navigation. Last is cost. Of course, navigation costs quite considerably on the initial investment. But if you are a high output unit where you require the benefit of navigation for more than 600 cases per year, then of course it really cuts down your overall cost of the functioning of the unit quite comparatively. And we know the cost of technology versus cost of complications is quite considerable. For example, in this Clinical Neurology and Neurosurgery journal, they found that in 2,783 patients in 12 studies, there were 56 patients who were sued. And screw malposition was responsible for 11 deficits. So this is a huge amount. And the amount of suing and what is almost everything is running into more than $1 million of sue. So if you look at that, then it becomes simple that the last thing any one of us want is a neurological deficit because it is a huge implication. So can you just be a navigated spine surgeon? No, I don't think. I mean, there is a big argument whether navigation will make a bad surgeon into a good surgeon. Definitely not. I mean, because the benefit of surgery or the good results of surgery is in making good diagnosis, good indications, good technique, and screw placement is a small but important part. So if you are bad in everything else, it's not going to give you good surgery. But a good surgeon can become a bigger surgeon or a better surgeon with navigation. You also have to be really careful that if you're embarking on a navigated surgery, even if there is any mechanical failure, then you should be able to complete it. You can't depend on the tool to make you a better person. As my professor used to say, a fool with a new tool is still a fool. So you really need to be a good spine surgeon before you think of a good tool. Thank you very much for this opportunity. Again,